EUS is highly accurate in diagnosing chronic pancreatitis. Information can be gained on the pancreatic parenchyma and duct, and 9 standard diagnostic criteria have been defined to estimate the likelihood of chronic pancreatitis. EUS is also very useful in distinguishing between inflammatory and malignant masses. The normal pancreas appears as a homogeneous structure with a single anechoic smooth duct running within. The body and tail have a fine, diffusely speckled salt and pepper pattern. The gland contour is generally smooth, but some margin lobularity is normal. The dorsal pancreas is generally more echogenic than the embryological ventral pancreas, the ventral Anlage. The transition zone between the darker ventral Anlage in the head to the brighter dorsal pancreas in the uncinate and body and tail is seen in approximately 50% of cases. The pancreatic head is generally more heterogeneous than the body and tail. The duct wall normally has a similar echotexture to surrounding tissue. The duct tapers from the head to the tail, with 3 mm, 2 mm, and 1 mm being average duct sizes in the head, body, and tail respectively. In patients over 60 years old, an additional 1 mm for the main duct in each section is allowed due to gland atrophy. Here is a normal pancreas on EUS and the corresponding histology. There are 9 accepted EUS criteria for chronic pancreatitis, including 4 parenchymal and 5 ductal. Calcifications are very specific for chronic pancreatitis and is considered diagnostic. In patients without calcifications, the number of endosonographic criteria is critical. 3 or 4 criteria are the best overall cutoffs. Less than 3 criteria essentially rules out chronic pancreatitis, and 5 or more criteria are highly suggestive of chronic pancreatitis. The Rosemont classification system divides EUS features of chronic pancreatitis into major and minor criteria. It has not been fully validated, and the standard classification system will be used for this video demonstration. This is a patient with chronic calcific pancreatitis. Multiple hyperechoic stones are seen throughout the pancreas, seen as bright, round, oval, and linear structures. Calcifications typically have associated shadowing, which appears as a hypoechoic or dark area stretching behind the stone. Calcifications can occur within the main pancreatic duct or the side branches. This is the EUS image of a patient with a dilated main pancreatic duct and the corresponding histologic finding. Dilation of a ductal side branch above 1 mm in diameter is considered abnormal. Hyperechoic or bright main pancreatic duct walls with a rail tract appearance is a further feature of chronic pancreatitis. Some degree of main duct tortuosity is normal. However, beading or alternating narrow then dilated duct is not. Hyperechoic strands appear as bright, linear structures within the pancreatic parenchyma. Of note, small echogenic foci or short echogenic strands may be normal when a high degree of magnification is used. Here we can see a patient with a number of hypoechoic foci and strands on EUS, and on histology, we see the corresponding fibrotic strands. Lobulations appear as defined areas of hypoechoic or dark parenchyma. They may be associated with confluent hyperechoic strands. The EUS image and the corresponding histologic image show the marked lobularities and fibrotic strands. Cysts are anechoic areas within the pancreatic parenchyma. They can be due to focal side branch dilation or inflammatory foci. All in all, there are 9 EUS criteria for chronic pancreatitis, and an increasing number of EUS criteria corresponds well with an increasing fibrosis score. This is a 56-year-old female with chronic calcific pancreatitis diagnosed 3 years ago, presumed to be hereditary pancreatitis. She had main pancreatic duct calcifications and had had a number of ERCPs for attempted duct clearance. She usually responded well. However, her pain rapidly recurred following the last pancreatic stent placement, and she underwent EUS evaluation. The pancreatic body and tail had multiple stones and a normal diameter duct. On uncinate pull-through, the uncinate parenchyma was preserved. However, there were multiple large calcifications in the pancreatic head, and the surrounding parenchyma was hypoechoic. In the apical view, the pancreatic duct was traced to the ampulla, and a hypoechoic mass was identified. It was significantly darker than the surrounding parenchyma, and it was not due to stone shadowing. Adenocarcinoma was diagnosed on EUS FNA. In summary, the EUS assessment for features of chronic pancreatitis is relatively quick and simple. EUS is accurate in estimating the likelihood of chronic pancreatitis, and it has an important role in distinguishing inflammatory from neoplastic masses.